Hello.
Hi all. Well, I'm glad that we can meet together today. Why don't we go around the room and introduce ourselves to each other. I'm Jessica Holtorf. I am the clinical nurse manager in the surgical unit.
And I am Kathy. I am in the ICU as a nurse educator.
And my name is Natalie, and I am the clinical manager on our medical unit.
So, Kathy, you were mentioning earlier, and that's why we met today, about you have a patient in your unit and who's on the intensive insulin therapy, and we wanted to try to explore the possibility of moving the patients that are on that therapy to the non-critical care area. So can you tell us a little bit about your patient?
Yes. We have a patient that came to us to the ICU. He's a gentleman that had been admitted to the DRHA in 2011. He has a couple comorbidities. He has a history of cancer, heart failure, and diabetic. Recurrent episodes of hypoglycemia. We haven't had much contact with him since 2011. We have all his records, his electronic health record while he was here. But since that time, because the systems in the different hospitals here or in the different hospitals in this community don't talk to each other, we're not quite sure what all he's been treated for or the treatment that he's received in the last couple of years. I'm hoping that will change with time because I was reading, I'm taking a class and we have this wonderful book on health informatics, and I had read somewhere that the United States, Nelson and Stagg's Health Informatics of Interprofessional Approach, said that the United States is behind a lot of the other nations, that we even the developing nations in technology. So my hope is with reform, healthcare reform, and the initiatives for meaningful use, that we'll be able to change that. So we'll be able to get some more of his history. That might be helpful. But the issue is that he is in the ICU, and he currently has a blood glucose that's running 350 milligrams per deciliter, and he has an irregular heart rate. We want to try to send him out to the medical floor once he's stabilized. The situation, as you probably are aware, is that just quite recently our ICU instituted the CDSS, the Clinical Decision Support System. It's a system that can provide tighter control for glucose, and we're new at it. The medical unit, as you know, doesn't use this system. So we're going to stabilize him using the system. And yes, I do know that there's some inherent problems right now in our ICU with the system because it is new. The nurses, we have a small percentage of nurses that are overriding the recommended insulin therapy because of, well, a lot of different reasons. I'll get into that in a little bit. But we need to get him transferred out to the floor, and we need to come up with a way that we can do that effectively and safely, and then just to have a discussion about maybe the future of implementing down the road the CDSS. Technology is changing, and we're trying to improve healthcare, so it is something that they might want to look at in the future.
Okay. Well, you know, as a leader in my unit, I have learned a little bit about the intensive insulin therapy, and I have some really serious concerns about whether we're ready to implement that yet. I think that we need to. I have some recommendations. Maybe you had said that that your nurses are having are overriding the recommendations, and I was found in my research when I just did like a quick little literature review that there was this person in Campion, and he had a list of colleagues who studied that about those overrides and the different factors. So I'm wondering what in your unit also, did you see the same things? He was saying that there's issues with the nurses having to manually enter the glucose levels once they check them.
This is the issues they found, and I'm surprised you brought up that study. I want to congratulate you for being so well informed. There was a study by Champion and Associates et al. It was actually done in the Journal of American Medical Informatics. It was published in 2011, and actually he did 2 studies. They did one study and a follow-up study.
I saw that.
They actually looked at the reasons why the nurses were overriding, because they wanted to figure out what the problem was, why they were doing it, and then maybe a recommendation to change that. What they actually found, the reasons why the nurses were doing it, there were actually 4 reasons. They were concerned about hypoglycemia in the study, and I found that our nurses, that's the reason why they're overriding as well. The study found that nurses would, and it was a small percentage of nurses that were doing it, probably about 5%, but the majority of the time when they did override it, they were giving less than the recommended insulin dose rather than more. They hardly found instances of when they override for more, but they're more concerned about the patient having hypoglycemia. So if perhaps the recommendation was to give a certain amount of insulin, they would choose to override it and to give less. And it's because they were worried about hypoglycemia. But what they found, as well as what I'm finding in our unit when I talk to the nurses about why they might choose to override, because we do get a report that lets us know when the nurse overrides, and they can put a comment in as to why, but it is because they're worried about hypoglycemia. The problem is that that individual nurse is not looking at the trends. So that was one reason, and I found that to be true in our unit. That's why I love this research article, because it's true to life and what we're finding in our unit. Also, they get concerned when there's comorbidities with the patient, and this patient that I'm referring to has a lot of comorbidities, and not knowing his past history and what exactly he's done over time with his insulin, they are worried. So that goes along with the trending as well. Also, they have a disagreement with the recommendation, and I think it might be a clear lack of understanding of how the system works and not trusting the system. Mm-hmm. We have a lot of tenured nurses, and they have good critical thinking skills, which you need to have. However, most of them are new to the computer world, and we find, and studies have shown, that if the nurse is a newer nurse and she's been raised in nursing school with technology, so she's very comfortable with the technology. The older tenured nurses, they have a harder time with it. So there's not a trust factor with that. And then the last issue that my nurses are telling me was also brought up in the study that was done, and that there's workflow issues. And the workflow issues that the nurses are finding that is hindering them is that there's some double documentation that goes on, because the nurses in our unit have to actually, they go and they get the blood glucose with the glucometer. They get the results. They have to enter the results actually into their nurses' notes as well as the CDSS, which then gives them the recommendation. So they're doing a little bit of double documenting. The other issue with the workflow is that if they have to give insulin, you know, the protocol which was programmed based on the patient's insulin, they may have to give they may have to increase the insulin drip, or they might have to give another medication, and it requires another intervention after that. That's timed.
Another glucose check.
Right.
Another glucose check, yeah.
So, you know, there are some workflow issues, not to say that it can't be worked out, and I think because it's so new to them, in time they will learn a rhythm. And I believe education is part of the process. Continuing education and familiarity with computers. I have some nurses on my unit that need some remedial computer work. I think that would give them a background and a basis. Mm-hmm. And there are a lot of, somewhere I read about a Tiger initiative that came up with some,
oh, sure.
I don't know if I have heard about that, but a group of nurses met some stakeholders to come up with some ways of helping nurses, and there are some computer programs for nurses. Right. Mm-hmm. So with being in education, you know, I provide those to my nurses as well to make them more familiar, and I think that they will, with time, choose with education and understanding and getting a workflow, override less. We are documenting the overrides, so I think down the road it might be something that, you know, the medical unit might really benefit, and we'll have a better continuity. We can talk about ways that we can help with that, but for right now, that's the situation with our patient in the ICU, and I'm hoping that you guys can, and as a committee that meeting about this situation and this patient, that we can come up with some ideas to help his transfer to the medical floor, and then ongoing down the road, be able to give safe, quality care to this gentleman.
Absolutely. Kathy, thank you so much for giving us that introduction to your patient and to the IIT CDSS that you have running. I think implementing it on, at least from the medical side of our unit, there's a couple things that I do worry about with this, and it's been shown that the CDS systems make it easier for patients or for to determine a lot of patient problems and things going on with our patients, and that's been shown in, for instance, in the CHO article that some of us have read. However, my biggest fear is the time constraint that it will put on our nurses. You know, in the ICU, typically, from what I understand, you guys usually have 1 to 2 patients, and it could be a little bit difficult on our unit with having to do frequent blood sugar checks and, you know, changing the insulin and getting it into the computer system and all of that every half hour, you know, if you have a low blood sugar. So that's my main concern about implementing this on our medical unit at this time.
Yes, I do. I agree with you on that.
I agree with you too, Natalie. I think that you know, as a magnet facility, we have certain numbers of hours per patient day, and that's increased in the ICU setting, so that having that tight control and being able to go back and do those rechecks and the reinterventions, that works really well right now in the ICU areas. But on the medical floor, that metric that we use to manage the staffing patterns is different. A nurse may have 6 patients, and you know, they may not have really the time with those conflicting priorities to follow up appropriately. So I'm concerned that we might see more overrides or more adverse events. I have a question, Kathy, on does the system currently have any way to remind the nurses of when the recheck is done? Is there an alert that prompts them, or are they relying mostly on their memory?
Well, that's a good question, but it also brings up some other concerns that we have. There are alerts, but as you know, in the ICU, there are a lot of alerts that are going on. They can choose to turn the alerts off, which is a safety issue that we are telling them that they cannot do. There's alarm fatigue that's going on with nurses right now. It's a
Joint Commission safety goal.
It is. It's a recommendation that we're very mindful of right now with alarm fatigue, and that is one of the issues that the nurses are, you know, dealing with. But yes, it does give them an alert. It is a high priority alert. They are not to turn it off. But their concern is also that they have another patient in the ICU. In our ICU, we care for 2 patients. and sometimes it makes it difficult to get to the other patient to carry out that task right at the time the alert goes off. Part of a workflow issue that we're working on.
And does the alert occur only in the computer system? Do they get the alert through any other devices at this time?
Yeah, the alert can interface to their, well, we are working on getting some handheld devices for them that would be able to alert them. Like I said, it's a new system that we just implemented. It's a work in progress. But yes, there are some ways that they can get additional alerts.
Well, what do you think about that, Natalie, about using smartphones or the tablets?
You know, I think that using smartphones in this scenario would benefit not only the nurses for reminders, but it could also, you know, smartphones and tablets have been proven and shown in studies that they can help improve patient satisfaction. There was this recent article in U.S. News about how hospitals are using smartphones, and one of smartphones and tablets. One of the things that patients are really liking is, you know, the physician or nurse can come in with the tablet and sit at the bedside with them and discuss and show them, you know, show them their labs, show them their x-rays, show them their chart essentially, and discuss with them everything that's been going on. And it's a much more patient-centered approach to nursing and healthcare. Not only from the patient side, but from physician to nurse or physician to physician, getting in contact with each other is much more simpler through using these types of devices. You have the ability to just pull out your phone, your hospital-approved phone, and call another physician or the nurse to assist you with something or for a question, which is a much quicker method than the traditional paging and waiting for a call back. The other thing with another article that I read about, this was through Fierce Mobile Healthcare, and it was more about smartphone and tablet use in hospitals, and it's currently estimated that over 50% of all hospitals in the U.S. use some sort of smartphone, smart tablet system. So one of the things I was thinking of in regards to our insulin therapy that we've been discussing would be to have some sort of dashboard on the tablet itself that we could transfer if the patient gets transferred from the ICU to the medical surgical floor. It would be a great way for the nurse to see trends in blood sugars as well as trends with insulin. You know, as that blood sugar is going down, are we having to increase our insulin significantly? You know, and maybe with these types of trends, hopefully it would be able to decrease the amount of overrides if nurses are able to see, well, they've been getting, 12 units of insulin in order to keep their blood sugar in this range, as opposed to, on our unit, giving somebody 12 units of insulin is something that could definitely cause our nurses some concern, as that's not a normal dose that we would be giving out. Yeah. So I think the smartphones and smart tablets could definitely help with that and having some sort of dashboard to watch.
Well, I think, that's a great idea, and I really like the idea of using a dashboard. I attended a leadership conference a while back where they demonstrated something similar to that, and I wonder if we can collaborate with our informatics department to develop a custom scripted page that can tell the whole story of the patient in one view. And this is what I brought the materials back so I can show them to you if you'd like. But basically, you can get the whole story of the patient in one view as a clinical snapshot, and they have found it to be very effective. In fact, the nurses use it to conduct bedside shift reports. So from shift to shift, they use that to share information. It has their medications, their lab results. It has education documentation of what's already been done with the patients. Great. And it also has computer links to other programs that are really good for the novice staff. So I think that if we're considering transferring these patients that are so complex from the ICU to the medical floors, I think that this would be a key tool that they could use. And it's interactive. I mean,
Absolutely.
think about it. The summary view of your patient. I think that it would really benefit it.
Oh, I really like that idea. That would help with the communication with ICU to med-surg, and would certainly improve the quality of this patient's care. So that was a great article to find and to bring back that information to our director of IT, who I know is very proactive in.
We'll need to loop them in.
Yeah, absolutely. Yeah. And with the smartphones and tablets that our nurses would have, another thing that we could have set up through IT is have our documentation system and our charting system and CPOE orders be able to alert them when they have new orders, or when when it's time to check that blood glucose again, just so we're not forgetting not forgetting when to check these. The only fear that I have with adding more devices in is alarm fatigue with our patients and our nurses, and because as many of you have read, I recently read an article by Sidebottom and Associates about that alarm fatigue is definitely real, and by adding more of these devices, it could definitely be adding that. It's just another sound for our nurses to be hearing. In this article, one of the nurses said, having all of these alarms, it's like having a call light going off all the time, and it just gets really old. So I think if we figure out a way to have the devices remind our nurses to check blood sugars, we'll have to definitely be mindful of the alarm fatigue that could occur with that.
Sure, but I think that I know that our society is getting so, smartphones are so ingrained in our society, and those push notifications that tells you that you have mail, it does prompt you to be looking at things, and
absolutely,
I think that it would help, and I think that I read that there are some systems that where you can actually document those blood sugars. It will populate right there at point of care, and then it goes into the charting system. So that might solve the problem that your nurses are having, Kathy, in the ICU, where there's that double documentation.
Yeah, we do need to look at some of the issues that cause workflow issues with the nurses.
Right,
That's a very important piece to them, and the face of healthcare with technology certainly is changing, and it's advancing, and we have to incorporate that, and keeping in mind, the nurses' education and everything we can do for them, because a lot of times, honestly, and my nurses have said this to me as well, sometimes they think that the technology that we're implementing is a way for management to, it's like Big Brother's watching them. And because it prints out reports, we can see that they've overrode, we can see the times, and we just have to come to an understanding that that's not what this is about. It's about safe, quality patient care. That is a perception that the nurses are feeling.
Right. Well, we're charged to under the Affordable Care Act to provide care that's high quality and contain costs. So it really is important that we explore how we can get these patients out of an ICU bed, because the charge is so costly. If we can, the Centers of Medicaid and Medicare Services, they have charged us with that task. So I think that we can come up with solutions which can maintain those standards of care while maintaining that quality. So,
absolutely.
Say we're able to get to a place where we're able to transfer a patient to say we have that dashboard created by informatics, that summary page. I think we need to set some defined transfer criteria for these patients for when they can be transferred to the floor. So what do you think about that?
I would absolutely agree with that. I think we need to have that criteria in place. I think one of the criteria would be we need to make sure that they have a stable blood sugar, that we're not seeing huge spikes and then having to change our insulin requirements frequently. I think we need to be, in order for something like this to work on the floor, it needs to be they need to be relatively stable with their blood sugars. As we discussed earlier, our nurses aren't able to do blood sugar checks as frequently as they are in the ICU. So we'll want to make sure that the blood sugar checks are every couple hours, where they're stable enough where they're not having to have continuous monitoring of blood sugars like they do in intensive care.
Because they just wouldn't be able to do a check every half an hour on a floor. I would personally like it to be minimum of 4 hours prior to transfer, and maybe a blood sugar between, I don't know. I know that the operational threshold is maybe different, but 80 to 100 milligrams per deciliter, perhaps, for 4 hours prior to transfer.
Yes, and they need to be off the CDSS for a period of time before they're transferred. So the protocol would have to be that it is discontinued, and then the patient is monitored. 4 hours might not be enough time. The CDSS should be taken off, and then the patient monitored. We could come up with a length of time, but maybe I'm thinking more 8 hours at least.
Just to make sure that our sliding scale is within appropriate range. I would agree with that. We want to make sure that the patient is stable before transfer.
Yeah.
Well, I would love to collaborate on a policy and protocol for transfer to make the transition easier.
Well, I think that that's absolutely necessary so that we are staying within our standards of care, because I would hate to have a patient transferred too soon and then have an adverse event. We cannot have that. So we need to have defined protocols for what the transfer criteria is. We need to get the buy-in from the physicians, too, that they would be comfortable transferring their patient to the medical floor, because that would mean that they would either be transferring care to another physician, or they would need to be coming outside of the ICU and seeing their patient in another location. Sometimes physicians, they want to stay in one spot because that's their workflow issue, too. They don't want to be going up and down everywhere. So we need to get their buy-in also. So that's another piece that we need to communicate. Are there any systems that you know of, Natalie, that you've heard about that can help with this, with the glycemic control?
Yeah. So I've done some research and read about, through a company called Glytech, about a device called the glucomander, and this device has been used. It's very safe. It's effective for patients outside of the intensive care units. It's not as invasive as having to get those hourly blood sugar checks. The device is able to monitor blood sugar and then give appropriate amounts of insulin, and it's a much safer method, and it would be much more manageable on either our medical or our surgical floor, because it wouldn't require such close monitoring as in the ICU with the IIT.
Great. And could we incorporate that, do you think, in the tablets and smartphones?
Absolutely.
Into the EMR?
Absolutely. We would be able to connect the glycemic control device. The glucomander is the name that comes to mind, but we'd be able to connect the information from that to our smartphones and tablets and be able to show the patient and discuss with the patient and family all of the, show them their trends and how they've been doing, and how if you eat this is how it's going to affect your blood sugar. You can see those spikes and falls with that.
Perfect. That's really important, because when the patients, when they are able to participate in their care and recovery, we empower them to stay healthy. I think that that's really important, that once they are past that critical phase, that we refocus on how we keep them out of the hospital, especially, and prevent those comorbidities like this gentleman. Do you know, are we able to use this data to benchmark performance?
I would sure think we'd be able to.
Well, that would be good. We can then report that out of how well we're doing as an organization in maintaining glycemic control for our patients.
Absolutely.
So say we're able to get, the summary page, and we develop the transfer criteria, and then maybe perhaps get the GlyTech, which would help the patients. Say we have that capital budget to do that.
Yeah, I was just going to ask about where if you know where we're at with capital. I know at the fiscal year we received some extra funds, so if we have a price, if we could get the vendor in to speak to us regarding what they could provide us with and the cost, then we could do an inquiry and find out if that was something that would be feasible.
Yeah, a value analysis. I think that's really important.
Absolutely.
And there might be grants out there to help us get this technology. There's such a huge push, like you were talking about, with implementing innovative and technology in the healthcare place. So we might be able to get a grant to help us fund.
Well, I am certainly going to ask our grant writer to look into that.
Yeah. So once we get all those things in place, I think that as a nurse educator, Kathy, you are going to be critical to the communication in rolling this out to the staff so that they are clear. I would imagine that you would need to get some super users, some staff members on board to help their peers, that see one, do one, teach one kind of thing, where they are helping to co-educate their peers along with you, because we will need to determine the skill validation of the staff and the clinical competency with these new systems.
Absolutely. Yes, and I think with our super users, I think it would be critical to have both experienced and maybe some of our younger nurses involved, as our experienced nurses have a lot more of that clinical decision-making background, but they may not have that technological background that some of the younger nurses may have. So I think maybe if we had a mix-up of the two of those, I think we would have a really good team ready to roll this out.
Yeah. You cannot lose that insight with the experience of the experienced nurses. That second Campion study, when they were talking about the overrides, and you were talking, Kathy, about the reasons why they were overriding, those experienced nurses knew that if they gave too much insulin, it would cause the patient to bottom out. And so they looked at the actual logic of the code, how it was programmed, and based on that feedback, they adjusted the dosing. So rather than multiplying it by 0.02, they went to 0.01. If we didn't have those experienced nurses involved in that, we would lose that. So I think that it's our role as leaders to be the champions for change, but also that we are using our own critical thinking and our experience so that we're not just running after the next shiny new thing, that we're really putting our resources to the best place, our money, our intellectual resources, so that we can really improve patient care.
Oh, very well said.
I absolutely.
So let's adjourn, I think, unless you have other things you want to talk about. I think we all have people that we need to be speaking with to try to get them to help us with this initiative, informatics, finance, see where we are with capital budget, and see where we are.
I think that sounds great. This was a great meeting, ladies, and it's great to discuss this technology that's coming out.
Yes. It was nice meeting with you.
Nice meeting with you too.
Should we plan another meeting in a couple of weeks, perhaps?
I think so. Let's maybe next month give us some time to reach out to the people that we need to, and then let them get their response back to us, and then we'll some of the people that we need to go to, like if it's the GlyTech, we might need to go to Value Analysis Committee, which meets at a certain time.
Right.
So let's give us a month so that we can work within our organization structure and really be effective to get this change going.
Okay, great. I agree. So I will commit to a couple of tasks. I'm going to speak with the director of ICU to ascertain the capital. I'll put that piece so she can take that. I will also speak with the grant writer because I think that she might be very helpful. I'll give her some information and she can start thinking about that. So I will take on those 2 tasks before next month.
Perfect. And I will continue the research and education into smartphones and tablet devices and see what may be the best option for our hospital. And then Jessica, I don't know if you want to maybe look into potentially getting a dashboard developed with IT for this.
I'll work with informatics since I have those materials from that conference that I attended, and I think I'll just do a draft of the transfer criteria, which then I'll send to you guys electronically so you can give your feedback, and then we can also send that out to our medical committee.
Absolutely.
Great.
Sound good?
Sounds great.
Okay, wonderful. Thanks, ladies.
Thank you.
Have a great day.
Bye-bye now.